Today, we're jumping right in to break down an absolutely vital clinical pearl for assessing primary myelofibrosis, or PMF. Specifically, we're looking at the Dynamic International Prognostic Scoring System, better known to all of us as DIPSS+. Now look, I know as medical professionals, you're literally juggling 1,000 different scoring systems, algorithms, and diagnostic criteria in your head at any given moment. It's incredibly overwhelming, right? But our goal today is to take this one specific scoring system and make it so brilliantly clear that you'll never second-guess it again. Not on the floor, and definitely not on your board exams. So get ready to streamline your thinking. Okay, let's dive into this. I want you to take a brief moment and actually reflect on your current methodology. When you're standing there looking at a patient's chart, or you're staring down a tough multiple-choice question about a patient with PMF, how exactly do you calculate their DIPSS plus score? What's your mental workflow like? I'm going to challenge you today with a thought. You might actually be making this calculation significantly harder and way more time-consuming than it needs to be. You see, the way we're taught the theory of a scoring system in textbooks doesn't always translate perfectly to the most efficient way to use it in real life. So let's get into Section 1, the conceptual trap, and defining DIPSS plus. To understand why this trap happens, we really have to look at the theoretical framework of the score itself. The very name, DIPSS+, actually creates a subconscious trap for test takers and clinicians because it strongly implies an addition. Conceptually, the calculation begins with a foundation of exactly 5 variables. We're looking at age over 65, constitutional symptoms, hemoglobin under 10 grams per deciliter, leukocytes over 25 times 10 to the 9th per liter, and circulating blasts of 1% or more. Because of how the scoring system originally evolved, your brain naturally wants to tally up this base score first. First the medical community established these 5 core variables, so we're kind of programmed to start there. Let's move to and see how this builds. Building on that foundation, the plus in the name DIPSS+ conceptually represents adding 3 extra variables. Basically, medical researchers realized that to get a more accurate, updated prognostic picture for PMF, they needed to add to those original criteria. So mathematically, in theory, you take your 5 base variables and you add these 3 new ones, 5 plus 3. It sounds simple enough when we're just talking about the concepts, right? Moving right along to Section 2, the 3 additions, or isolating the plus. Let's really isolate the specific clinical markers that make up these 3 extra points. It is absolutely crucial to internalize what biologically drives this updated prognosis in your patient. First up, a platelet count of less than 100 times 10 to the 9th per liter. Number 2, transfusion dependence, meaning the patient relies on red blood cell transfusions. And number 3, an unfavorable karyotype. I want you to essentially take a mental photograph of this list. Platelets under 100, transfusion dependence, unfavorable karyotype. These are the exact 3 distinct additions that separate the old system from the new system. However, we need to talk about Section 3, the clinical reality and practical application. Now, what's really interesting about this slide is the massive pivot between theory and practice. We've spent the last few minutes discussing the academic, methodical theory of how the score was built, right? 5 base variables plus 3 new ones. But when you're in the middle of a high-stakes board exam, or you're managing a packed patient load in a crazy busy hematology clinic, that academic theory of 5 plus 3 just doesn't matter. Efficiency matters. Look at the contrast here. On one side, we have the theoretical 2-step math problem. Calculate the base score, tally those 5 variables, hold that number in your head, then find the 3 additional points and add them together. On the other side, we have the practical survival strategy, treating it as a single unified checklist of 8 items, no compartmentalizing. So the crucial point is, simply score all 8 variables directly. Save your time, save your sanity, and avoid unnecessary calculation errors. Never ever calculate a separate, foundational DIPSS score first, when your ultimate goal is the DIPSS plus score. Just count up all the variables present out of the total 8. If your patient has the age factor, the white blood cell factor, and an unfavorable karyotype, you literally just count 1, 2, 3. You completely bypass the conceptual trap of the word plus. This streamlined method removes a whole step of mental math, which, let's be honest, is exactly where those simple, frustrating errors tend to happen when they're stressed out on the wards or during exams. Which brings us to our final thought for today. How will you approach your next primary myelofibrosis assessment? The next time you see a question asking for a DIPSS plus score, are you going to fall for the naming trap and do the clunky 2-step math? Or are you going to look at the patient's data, run straight through a single, clean list of 8 variables, and get your answer in half the time? By making this one super simple shift in your perspective, moving from conceptual theory to practical reality, you're going to save yourself some invaluable cognitive load in high-pressure settings.